Hello everyone, this is Rachel Garcia and I'll be discussing about pulmonary tuberculosis, which is one among the top 10 leading causes of mortality in the Philippines. And actually, it affects not only our country but globally. Now, pulmonary tuberculosis is also known as consumption disease, white death, poor man's disease, Cox disease, King's, evil tuberculosis. Tuberculosis is an infection which is attacking human of all ages and can infect nearly every part of the human body. Pulmonary tuberculosis, that is primarily tuberculosis of the lungs, which uh, makes up the vast majority of the cases. In the ancient times, Neolithic skeletons in 4500 BC and Egyptian mummies in 1000 BC have been found with tubercular lesions. So this disease is actually a problem that exists back in prehistoric years, and it says that it is known as consumption because a Sanskrit word translation shows a wasting disease. So meaning to say the bones has been reduced in size. Okay, and another one, it is also known as thesis in the word of ancient Greek, which used to describe the disease. White death is relatively associated with the incidence of epidemic in the 17th century, where 100 years ago, it caused a lot of deaths among Canadians than any other single cause. Another one is the poor man's disease. Poverty fuels tuberculosis. TB is a disease of poverty. It is widely recognized that the poorer the community, the greater the likelihood of being infected with TB. Also, uh, TB is known as King's evil disease. It is widely believed that the person affected could heal after a royal touches the sick individual in France and in England. Moreover, Cox disease is another name for pulmonary tuberculosis. The famous scientist Robert Koch was able to isolate the tubercular bacillus and presented this extraordinary result to Society of Physiology in Berlin in March 24, 1882. Hence, the disease was named after him. The causative agent of pulmonary tuberculosis is Mycobacterium tuberculosis. The domain is bacteria and family of Mycobacteriaceae. Mycobacterium tuberculosis has unusual waxy coating on its cell surface, primarily due to the presence of myco mycolic acid. It can appear either gram-negative or gram-positive. Acid-fast stains such as Ziehl-Neelsen or fluorescent stains such as auramin are used to identify microscopic Mycobacterium tuberculosis. The physiology of Mycobacterium tuberculosis is highly aerobic, requires high level of oxygen. That is why it primarily affects the lungs. Primarily a pathogen of a mammalian respiratory system. It infects the lungs. Now, how do we get this disease? So there are, this can be acquired either airborne droplet. TB are spread through the air from one person to the other, and TB bacteria can put into the air when a person with TB disease of the lungs or throat coughs, speaks or sings. people nearby may breathe in this bacteria and becomes infected with it. And that is according to Center for Disease Control. However, TB is not spread by shaking someone else's hands unless the hands of that individual was used to cover the mouth when he coughs. So and the hands get contaminated with the droplet, and you do your shake hands, and then you wipe off your hands. So that can be a possibility. Now, sharing food or drinks, touching bed linens or toilet seat. Okay, you cannot get it also from sharing toothbrushes and kissing. Now, diagnostic tests. So how do we diagnose the tuberculosis? First, we have the MAN2 testing, which is the tuberculin testing or the TB test for purified protein derivative, which can be an additional test to confirm TB disease. Okay, is performed by injecting a small amount of fluid called tuberculin into the skin in the lower part of the arm. This test is read 48 to 72 hours by a trained healthcare worker who looks at the reaction we call induration. So let us look at this. It is said that 10 millimeter induration is considered positive for those people with normal immune system, but for those with weakened immune system like HIV, 5 millimeter induration is already considered positive with PPD or MAN2 testing. Second one is the acid-fast bacilli. A sputum smear or a specimen often indicates that there is presence of Mycobacterium. Acid-fast microscopy is easy and quick, but it does not confirm a diagnosis of TB because some acid-fast are not acid-fast are not Mycobacterium tuberculosis. Therefore, a culture is done in all initial samples to confirm the diagnosis. However, a positive culture is not always necessary to begin or continue treatment of tuberculosis. A positive culture confirms the diagnosis of tuberculosis. Culture examination should be completed on all specimens regardless of AFB smear. Laboratories should report positive results on smear and cultures within 24 hours by telephone or fax or to the primary healthcare provider of the local TB control program as required by the law. Another one is posterior anterior chest radiograph or chest X-ray is used to detect chest abnormalities, lesions which may appear in the lungs. It may appear in different size, shape, density, and cavitation. These abnormalities may suggest TB but may not confirm a diagnosis of tuberculosis. However, a chest radiography may be used to rule out a possibility of pulmonary tuberculosis in persons who have positive reaction to tuberculin skin testing or TB test with no symptoms. And then we also have the gene expert. It is the new test for tuberculosis. It can find out the person is infected with TB and also if the bacterium of the person has resistance to the common TB drugs, okay, like rifampicin. Next, signs and symptoms. Signs and symptoms of tuberculosis depends on the location where the TB or the tuberculosis bacteria is growing. TB can usually grow in the lungs. So if the TB grows in the lungs, you usually see the following signs and symptoms: fever, night sweats, fatigue, chills, loss of appetite, chest pain, coughing that lasts 3 or more weeks, and the pathognomonic sign is coughing up of blood, or we call it hemoptysis. Hemoptysis is the pathognomonic sign of TB. So given those signs and symptoms, we can actually rule out that the nursing diagnosis for TB is somehow similar with pneumonia, except that in TB you also have your hemoptysis. So I think one way that you should pay particular attention to is when patient develop hemoptysis, you have to position the client in leaning forward, okay, and then provide some ice chips to prevent the coughing out of blood. And then for extrapulmonary TB, nursing diagnosis may be variable depending on the area that is presenting signs and symptoms. Now for the pharmacologic management, so management will vary depending on the category identified of the pulmonary tuberculosis or the type of tuberculosis. Now for category 1, new pulmonary TB, new miliary TB, and new extrapulmonary TB except for CNS, bones, or joints. While as the CNS TB, TB of the bones or joints is classified under category 1A. And then category 2, we have the retreatment of rifampicin susceptible PTB and extrapulmonary TB except that of the CNS and bones and joints. And category 2A are the retreatment of rifampicin susceptible CNS, bones, or joints. Now, for the pharmacologic management, the regimen for category 1 is you take 2 HRZE, H for isoniazid, R for rifampicin, Z for pyrazinamide, and E ethambutol. So 2 months that your patient will be receiving these 4 doses. Well, plus 4 months of treatment of isoniazid and rifampicin. For category 1A, the patient will be receiving 2 months of isoniazid, rifampicin, pyrazinamide, and ethambutol, plus 10 months of isoniazid and rifampicin. So a total of 12 months. Category 2 will be 2 months of isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin. And 1 month for isoniazid, rifampicin, pyrazinamide, and ethambutol. And 5 months of isoniazid, rifampicin, and ethambutol. Then this will be a total of 8 months. While as category 2A will receive 2 months of isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin, and then 1 month of isoniazid, rifampicin, pyrazinamide, ethambutol, and 9 months of isoniazid, rifampicin, and ethambutol, and that is a total of 12 months. Next is pharmacologic management for the CNS will be as follows. So, 2 months of isoniazid, rifampicin, pyrazinamide, and ethambutol, plus 10 months of isoniazid and rifampicin, so a total of 12 months for CNS type of TB. For bones and joints, you also have the same type of management. For lymph nodes, this is quite shorter, so you have only 4 months of HR or isoniazid and rifampicin. So the same thing goes with pericardium, pleura, liver, GI peritoneum, kidney, and genitourinary tract tuberculosis. You have 6 months of treatment, which gives strong recommendation and high quality evidence of pharmacologic management. Basically, tuberculosis is prevented by receiving BCG or your Bacillus calmette-guerin during the birth, and it should have been prevented, okay, with proper break in the chain of infection. So we hope to see the Philippines in the future to be tuberculosis free. Okay, see you again in the next discussion. This is Rachel Garcia.